Done. So sorry, I think that they changed some cables from the GMC. So the plan for today is that I will talk first, just the normal physiology about pain, that you know most of that because you have already a mixture of these fibers, of this pathway last week. And then Dr. Sarah Turia will talk about the clinical management of pain. So she runs a clinic in Milton Keynes, yes? And then you have a break, and then we have second lecture, and then we go to the group work. Okay? So to start, so it's just a definition, a formal definition about pain. What is beautiful about pain, when we were talking about sensations and somato sensations, is how pain is an example, and I hope that I transmit that for you, of a type of sensation that does not only, it starts in the periphery and is a product of the periphery going to the central nervous system, but how is an example of that story about perceptions being different from sensations and how much is modulated by the ascending pathways that controls the ascending pathways. Okay? So just a definition, an unpleasant sensory and emotion. Why sensory and emotion? Because it has an emotional component that changes the sensory. Several times I'm going to give examples that you don't need necessarily to have the sensory activation there, and we can still have pain associated with the actual or potential tissue damage. So we also say how much, Suhai. So we say how much. We have Suhai, so I can tease Suhai through the lecture, and then you wake up. The idea that is protective, so the idea that pain also exemplifies how is a sensation that is so needed for us, that despite that is unpleasant, is needed because protects our body, protects our lives. Okay, so the first slide is just showing how pain is everywhere, and pain and suffering. So that is a very interesting point. What is suffering and what is pain? So I know much more about the research of what people do in pain and suffering. So you will see some of these slides that some of the publications of a professor that if you are interested in pain, I was talking to Sarah and she knows as well, and she agrees with me how nice are her talks. Irene Tracy. So Professor Irene Tracy, she has an Institute of Pain in Oxford, and she has amazing stuff being done, and you are going to see some MRIs, function MRIs of people who are suffering and how suffering can activate the same areas of pain just by looking and sympathizing and just looking someone over pain, how can activate in our brain similar areas of someone who has experienced pain itself. So there are very interesting points about what people are doing in research about that. So I put here some words as well in red. So alerts. So pain alerts us, yes, and has triggered these appropriate protective responses. The problem that we have with pain, so pain is necessary. So we say that pain is necessary for us. It's not good. It's unpleasant. Nobody likes pain. And as you are going to see, different from all the other somatosensory sensations, it starts in that receptors that you saw, dorsal root ganglia, goes to the spinal cord like all the other sensations, but it's different. Pain is very different from just touch. Yes? It's unpleasant. Not only that, it makes us to not be able to do anything. Yes, so your attention, your emotion, so it will trigger many more areas than the S1 and S2, somatosensory 1 and somatosensory 2, that we were talking about. It will modulate other areas. So, and unfortunately, what happens in pain is that pain can become chronic, and that's the big business that I assume that you're going to see. Sarah says that she treats not just the chronic pain, but I think chronic pain is the big business, is what makes lives of people so miserable. And we are going to talk a little bit towards the end. I will put some slides. I have some slides that connect a bit with what Sarah is going to talk. So is the chronic pain, yes, is this transition. So unfortunately, pain, yes, from being just a warning signal, yes, that protects us, can become chronic and debilitating and make people to not be able to do anything, to not work, yes, to not live their lives. But chronic pain involves a lot of changes, and research has shown, and you're going to see, that promotes and provokes certain changes, starting in the spinal cord, and I'll show some slides about that. And it's not just, so there is a modulation, there is a question of how much this is not physically represented, but there are evidence that changes circuitries when it becomes chronic. So that's saying that I was talking before, chronic pain, yes, is considered the pain that is more than 3 months. Is that correct, Sarah? So 3 months. And is the large medical health problems develop everywhere, cost a lot of money, associated with mortality, and it's the management and the treatment that is now have been invested to make people's life better. And some innovative methods are being come along, but it still needs more. So I was talking about management, about these stories about the stimulation of areas in the brain, stimulation of nerves. So all of that had improved much more than what people knew before. So why you need to know the basic circuitry, why you need to know how pain is transmitted, for you to understand all these clinical applications. So I was discussing, it's not just chemical, and when I was talking to her, we were talking about which type of drugs, which type of receptors. So when we talk about normal physiology here, it's for you to understand what are you giving to your patients. So not just chemical treatment, but physical treatments to either block areas, to block the transmission, to block the pathway. You can take out areas that's not very much done, but the stimulation of areas more and more. People are doing that, stimulation of nerves or stimulation of spinal cord. So you saw that last week. So that is, any sensation happens, it starts like that. So any sensation, it starts with a number of stimuli that is now going to interact with a receptor. So what are you seeing here? A receptor. In the case of the pain, where are the receptors? Skin or muscles? Skin. So our terminal, free nerve terminals in the skin. So they are not encapsulated, so they are all free nerve endings. And you have here the transduction. What is transduction? Transduction. So high. Transduction. What is transduction? Transformation of energy. So the stimulus that causes pain, remember, we say that is extremes of temperature, extremes of mechanical variation, or chemical, yes, like in the case of inflammation, substance that can now be released by tissue damage that also affects these type of receptors. So we call these receptors nociceptors. We call them polymodal because they can be mechanical, thermal, or activated by chemicals in the skin. Then we have the transmission. So this guy here is a dorsal root ganglia. So you saw that is the anterolateral system. Remember this story, the anterolateral system. So you have this neuron that the end is the receptor. Dorsal root ganglia neuron arrives in the spinal cord. They simplify here very much because what happens is that arrives in the spinal cord and makes synapse with a second neuron. And this second neuron is the one that is going to cross. So an example why is important that you know. So hi, I'm going to put you here in the first chair in front of me to stop talking. So what is the importance of knowing that is if we know that the fibers cross, yes, you will see that problems, syringomelia that you're going to see in a minute, is a problem of pressure that happens around the canal. And if it arrives around the canal, we'll get specifically pain fibers because the pain fibers are the ones who cross at the level of the spinal cord. Yeah? Okay? So then what happened? They ascend laterally in the spinal cord, antero, dorsal, posterior, anteroventral, anterolaterally in the spinal cord. So they ascend in the spinal cord, and then they will synapse in the thalamus, that's not shown here, and then the third neuron there in the thalamus, in the ventral posterior. And also remember that pain fibers is stopping other nuclei in the thalamus that the other ones will not, and then goes to the cortex like the other fibers, touch, proprioception. But we'll go to more areas than that. So this is just a simplification. They put here the other pathway. No, sorry, this is just the descending pathway. They didn't put the other pathway here. So you know, last week we talked that there is the anterolateral, and there are the other ones that are taking information from touch and proprioception that we call dorsal column medial lemniscum. This one here, they are showing the descending pathway. So what is that? Ascending pathways, all the sensations will go through an ascending pathways. Descending, you were told that they are motor in function, yes? But in the case of pain, we have this difference. It's not that any other sensation does not suffer modulation, but pain, much more than any other one, it is well recognized that we have a number of fibers coming down and modulating the brainstem, and the brainstem modulates the spinal cord. Areas in the brainstem that you're going to be aware that are very famous, PAG, periaqueductal gray. There is another area that is the rostral medulla, yeah, that you're going to see. So there are some areas in the brainstem that they are well known to have a number of peptides that controls these guys who are making synapse here. So they are all going to modulate this first synapse that's not shown there, yes? And then what happened? You modulate what is being going up. Okay? So that is different from pain specifically, is the presence of these descending pathways. We have to keep in mind that nociception is different from pain. That means sensation is different from perception. So one thing is nociception, yes, non-conscious. So remember the same story of what is sensation, what is perception. So now I can have an activation of my receptor, and this receptor can go to my spinal cord, come and make me to have a reflex. But if that is non-conscious, does not reach my cerebral cortex, so that is considered just nociception. So non-conscious neurotraffic originating with a trauma or potential tissue trauma that informs your central nervous system that something is happening, and you take that member, that part of your body away. So acts very much as us protecting our body through reflexes, but is non-conscious. Pain is a different business. It's what we call a type of perception. So it's complex, unpleasant awareness of that sensation. And is hugely modified by our experience, by our expectation, by the context, by culture, yeah? So more and more, and you see, I know by my background in research, but Sarah sees that in clinic and we talk about, and that's the nice thing of interacting in these two ways. Expectation. You're going to see the research now, what people are more interested is about these psychological components, about if you think that the treatment is going to work. So you will see one of these slides in a very recent paper that I put here, where the patients, yes, were believing and were told by the consultants that these will work, and the importance of that, and with other ones that would not have that. So they had like 3 conditions where the patient would have a positive expectation or no expectation or a negative expectation. That can be, oh, that doesn't work, didn't work in my friend, is not working everywhere. Yes? So the power of these expectations, the context that happen. Why? If I need to save my life from that experience, so pain will be felt in a different context depending on that situation. We know that can happen, can have the origin, can be somatic or visceral. Somatic from our skin outside, or visceral. Why? Because we have also receptors for pain inside our body. So you're going to see something about referred pain. You heard this before. You're just putting together stuff that you have seen before through your course. So, and we have this link together where now the origin of pain can be visceral, but we sense in an area that is from our soma, from our external periphery. Give me an example of that. Angina is easy. It's the more classical that everybody refers in a lecture, is telling Look at the example of angina. When the patient starts to feel areas in the arm and in the chest where the physical compression, yes, is coming from the heart. Okay? And gives a sensation, elicits sensations, yeah, with autonomic, somatic, endocrine, emotional response. So pain is not just a motor, it is a sensation that will lead to a perception, that will give us responses that is not just somatic, like, I will do something, I will respond to my touch, yes? So it will give us emotional responses, autonomic, yes? So it elicits much more responses on us. So that is again sensation leading to perception. Nociception leads to pain. Okay? Why? Because the information that comes from the receptors will come to the spinal cord and go up. Yes? So you can have a response before you have the conscious perception, but we say that nociception leads to pain, but not necessarily, yes, as you see, there is really an activation of a receptor every time that we have pain. So how much pain experience will depend about lots of things. And some of the things that people are more and more acknowledging of that. So of course depends on this, guys. So to start here, depends of these fibers being activated by the nociceptors, can be amplified by injury, by tissue injury that you're going to see in a minute, that we call sensitization. Yes? So then goes to your spinal cord and go up, but we have this descending modulation here. So will depend, yes, on the cognitive set, attention, distraction. So attention is huge, well known. How much people pay attention on that pain or not, and the effect on that in MRIs, yes, they can see, visualize in function MRIs that. The context, beliefs, expectations, yes, that is very much being researched. You're going to hear about placebo and nocebo. Have you heard about nocebo? Okay, so what is placebo? Something, what? Too high. What's placebo?
Not active.
Not active. What is that? What does it mean?
It's psychological. Psychologically.
So there is no chemical substance in what you're giving, yes, but it's an effect, yes, that you have on the pain, yes, but it's not coming from any particular chemical drug that you're giving. So depends on our beliefs. Nocebo is the opposite. Is now is the negative effect that I have. Yes. So if I have a belief that this is not going to work, yes, or if I have a negative experience, a negative effect that I have, yes, that will influence me to have more pain. Yes. So that is nocebo. Mood. So how much if you're happy or if you're sad, yes. Chemical and structure itself, yeah, if you have degeneration, if you have any problem. But more and more, people are acknowledging all these other components here, yeah, mood, context, cognitive set, and you will see that this is addressed and treated in a pain clinic, not just giving drugs to people or doing stimulation to people. So when we were talking that where pain can come from, receptors, nociceptors are not just in the somatic, in our skin, but also internal organs. So this is what we call refer pain. It's a very famous term to understand that not necessarily you are going to refer the pain to the origin of the pain. And to understand that, we just have to understand the entrance of the dermatomes, of the fibers in the spinal cord. So an area in the skin that enters through the same nerve, through the same dermatome of a viscera, you are now going to converge to the same second neuron. And now the brain is incapable to know if it's coming from there or coming from here. Okay? So that is the idea. So in lamina 5 specifically, you learn that all the fibers of pain are coming very superficial in the substantia gelatinosa 1 and 2. But you are going to see as well later, you saw that before, that they do synapse with a neuron that are also in layer 5 that is there. So converge areas that are either internal and external. So that's just a definition of what is referred pain. Sensation of pain in an area of the body distant from the origin of the pain. Most experience is experienced cutaneous. Why? Because we have more sensation, more receptors from there. So you experience as cutaneous when in reality comes from another area, from a viscera. That is the example of angina. So the areas where the patient feels pain because it's coming from the same converging in the same neuron in the spinal cord. Yeah? So that's just an example of a referred pain. So you're going to hear that. So that is the neurons that we were talking. So what you see in that slide is back again the receptors in the skin. Now it's not just the nociceptors, but all the other ones. So we saw last week that we have these other fibers, the A beta from the skin, yes, all touch and temperature. Temperature comes from here, but touch comes from here. Heavily myelinated, fast conducting fibers. Yes, proprioception is missing in this slide because it comes from the muscle and articulations. So imagine that this is just the skin. So all the noxious stimulus and thermal comes from these two. They are thin, either a little bit myelinated or no myelinated. So A delta and C fibers. So look where they come to the spinal cord, very superficial. The green ones and the red ones. That ones are the nociceptive ones, the ones that are bringing information from pain. But then they synapse here, yes, and they go to another neuron that is in layer 5 that now is going to converge. So these neurons in layer 5 is said to be wider dimension. I don't know where it comes from. But these type of neurons are the ones that converge two types of things. Converge the information that comes from internal organs and external organs, but also what are you seeing converging here? The touch ones, the tactile ones, the other sensations, somatosensory, with the pain one. This will be extremely important to remember this picture in your mind to understand a theory that explain a treatment that is the TENS. Yes, so we the gate theory of pain. So you're going to see what's the definition of TENS? Electric transcutaneous nerve stimulation. So there is a. Let me show you. You saw that. We come back in a minute. So they found out that. I think that it starts in pregnancy, is being used in many other situations. But they found out that now by stimulating, just rubbering the skin of the location where the person is feeling pain, where pain is coming from, just rubbering there, so tactile sensation, would alleviate pain. So everything starts, most of things starts by something that works, that finds that this type of manipulation works. And then people have to understand what is happening there in the nervous system to try to explain, and people do models. So through this idea that now by putting some electrodes, this is just electrodes to a battery, and stimulating, yes, the area where pain was coming from, would alleviate pain, would relieve pain. And that led people to, scientists, to come along and try to understand what was happening, what was going on. So if you look here back in our spinal cord, I come back to that once, the information of pain is coming here, but it's converging here to the tactile one. The blue one is the tactile one. So now something is happening on this neuron that the blue one is inhibiting, yes, the other ones that were coming, yes, and now that ones were winning the competition. So they postulate this gate theory. So that was done by a scientist, a neuroscientist called Merzenich in 1965, and became very famous to explain how we modulate locally. This is modulation local, yeah, but that is happening in your central nervous system. So, so that is what you understand here. So you have the large diameter fibers, yes, the A beta fibers, and you have the small ones, the A delta and the C fibers, not just the C. Some books will just present the C, doesn't matter. But what you're seeing here is that these ones, they are large myelinate, they are faster. And they are going to come here and excite this neuron, and this neuron is going to inhibit that one, yes? So, and now the PEN one is going to inhibit that neuron. So these ones will come first, yes, because they are faster. And they are going to now excite this one that inhibits that. So the information of PEN that is coming along here is not going to be taken, yes, because these guys are faster and stimulates that one, it stimulates that directly, but indirectly they will inhibit that because this will happen before, stimulates this, and that one inhibits that one. So any information of PEN that would be coming here is going to be blocked and is not going to go. So in this way, they found out how presenting touch together with PEN in the area where PEN is coming from can alleviate and would explain the action of this machine. So the A beta, the faster ones, the tactile ones, yes, and the alpha, yeah, that comes from the muscles, from rubbering your skin, yes, they will stimulate these inhibitory interneurons, yes, and they would inhibit the PEN afferents that were coming there, yeah. So then they would inhibit the firing of the spinothalamic, the PEN pathway, okay. So that is what we call the gate theory that explains the 10th machine. It's said to explain other modulations as well. So just coming to the slides that I jump was just to show us that we have two types of PEN. So just by understanding the type of receptors are the same. So the receptor bit, the end bit, is all free nerve terminals. But now what happened is this fiber, this axon, is different. The C1 is unmyelinated and very thin. The other one is a little bit myelinated. So this type of activation, when we activate C fibers, we have one type of PEN. That is what? So dull, yes, poor localized, yes, as a second PEN. So when you record from these two fibers and you present a stimulation here, they see this type of recording. Yes, so the first one is faster. This one here is faster. So that is the peak. The intensity of perception is here. Yes, so this is time. So first, when you stimulate this area of the skin, you have this graph here. You first activate that because it's faster. And then after a while, you have an activation of the C fiber. So just by understanding that information of PEN is coming through two types of fibers, explain these different sensations of these different perceptions of PEN that we have, either a sharp PEN or a more diffuse PEN, non-localized PEN. So they are product of the fibers, and that is the idea that, okay, so if possibly we could block one and not block another one. So that's more complicated, but we need to understand that it's a product not just by the stimulus itself, but the activation of the fibers. Just talking still from the first neuron that is carrying the PEN, local anesthetics will block there. So local anesthetics, what did you learn in membranes and receptors? Blocks what? Which type of channel? Sodium channel. Sodium channel, voltage-gated sodium channel. So blocks any conduction of fibers. So that is one way to alleviate pain. You're going to see in a minute more ways to alleviate pain. So just to, before we go along, to remember the tracts. So this red one is some books called spinothalamic. Remember that it's not wrong to call spinothalamic, despite that is not everything goes directly to the thalamus. But a lot of books call it spinothalamic. It's the pain and temperature. Comes inside the spinal cord, dorsal horn, yes, synapse with a second neuron, cross, and I send laterally in the spinal cord. I send laterally until goes to the thalamus, to the ventral posterior lateral thalamus, and then goes to the cortex. The other pathway that we saw last week, yes, is the one that is dorsal column medial meniscus, that is responsible for the tactile and the proprioception information. So that we know that these two fibers in the brainstem medulla, pons, midbrain, they run closer together, yes? And they go to the ventral posterior lateral, but they are not going to the same neurons, and the pain one will go to many other places. So another point of understanding why we need to understand this traffic, why we need to understand where these fibers run, yes, is because certain conditions, so if we start by that one here, the syringomelia one, so it is a problem that happens in the spinothalamic tract, because the spinothalamic tract is the one that's crossing in the spinal cord. When central canal distends and compress, and will compress what? The fibers that are crossing. So it will damage only the decussating fibers that are only the fibers from pain. So you can have a condition that is caused, yes, by a compression of specifically fibers, but that is the importance of you understanding where the traffic happens in our spinal cord. Another condition that can happen, so remember that apart from these two pathways, we have the trigeminal pathway. And the trigeminal pathway, yes, cranial nerve 5, brings information, not just pain, but everything, yes, from the face, yes. And then I put a slide because Justin asked me about where they cross. They will cross level of brainstem, yeah, different levels, but we can also have a condition, trigeminal neuralgia, that now, so it said that you have now a compression of this ganglion. So these neurons that are also dorsal ganglion neurons that are coming from the face, coming here through the trigeminal, so they can now be blocked, yes, so now can be damaged, the trigeminal ganglion can be damaged, yes, not this outside here, but here. So the main sensory nucleus of the 5. So all these first neurons comes and make synapse here, yes, and that will be this trigeminal ganglion, yes. And now, if they are compressed by a specifically artery, and the treatment would be displace, for example, these arteries. So they can be compressed. These fibers from the trigeminal can be compressed by an artery, and that is the explanation for this trigeminal neuralgia. So just because we were talking about where the trigeminal fibers cross, so this is trigeminal entrance here, and we'll cross in two different levels. Either cross here in the level of medulla, comes down, cross in the level of medulla. This is the A delta ones, the a bit more faster ones. And the other ones, the blue ones here, yes, that are the A beta, so that is not the pain ones. So the pain ones that are going to cross at that one, yes, and cross the level of medulla, because that one will be just mechanoreceptors, yes, and that ones here will be just proprioceptors. Yeah, so cross, that is the answer, cross mainly at the level of medulla. Okay, so now we come to more the idea of what happened. So we heard before about these pathways, where they were going, and they will arrive, as you saw, simplistically, we say arrives here in the S1 area. And there are that idea of the homunculus that we saw last week, where the representation of the legs are medial, face is lateral here. Okay, but pain goes to many more areas. So pain goes to many more areas. So what do you see here? Pain fibers, yeah, going to the spinal cord, going up, yeah, through these pathways that we were talking, but now goes to many more areas than just the primary somatosensory cortex. So the primary sensory cortex is there. So that is function MRI, just showing activation areas where is activated by pain. I'm going to take this guy here. So we find that there is a network, yes, a variable set of signatures that explain pain, depending on the situation that pain is experienced. So which areas they are more popular? So all of these areas highlighted here are areas that are being activated by the information of pain, not just the primary somatosensory cortex. So we know that the thalamus is going to be activated because from thalamus is going to the cortex. So you heard thalamus before. The periaqueductal gray you heard before because it's an area for modulation down. Yeah? This rostroventromedial medulla is another guy that you're going to hear today is modulation down. Yes? Modulation down. So this is brainstem. But hippocampus is memory area. Is inside the temporal lobe. So our memories influence our pain. Of course, if you had a previous experience, will have to do. Amygdala is an area for emotion, for inside the limbic system, is also being activated there. Insula, you heard in the first week, that is the representation of the body, is that hidden lobe, yes, in our temporal, between the temporal and parietal. Insula is really, from my understanding, where people are concentrating, this group, this Institute of Pain, is concentrating a lot of research. Why? Because they find that area, the insula, that is the representation of the body, they have been implanting electrodes experimentally. It's not done for clinical so much, for controlling chronic pain. So insula is being appointed as the future areas. It is the new center, and a lot of research is being done there. Putamen is an area for attention. Attention is important for pain. Yes? So posterior parietal cortex is that cortex that we were talking about, the patients that have hemineglect, that ignores attention, that ignores half of their body. Yes? So it's an area between the parietal cortex that has to do with how much the integration between the body and the space. So it has to do with attention. So that is very much prefrontal cortex, because it's decision making. Yes, it's the thinking area. Cingulate cortex is another, top of the corpus callosum. So cingulate cortex is another big business in pain, where people are putting DBS, deep brain stimulation. So anterior cingulate cortex and insula are two very important areas. So there is a lot of research about that, the importance of insula, fundamental role for the insula. That's the insula is that area, yes, that you can see hidden. It's like a hidden lobe. So just the idea that significance of insula for the awareness of body, and has been pointed as playing a big business in descending. All these areas, they are controlling, they are being active by paying more attention, by memories, by emotion, and controlling pain. So as I said before, if we just so the idea of emphasizing pain. So if you're now experience physical pain, yes, activate similar areas of people who are just feeling empathy by the ones who are suffering. So if you compare here, the green is when you are really experience pain. The red is when you see people experience pain. So what can you see is that is preach activating similar areas. So you might be asking, why do I need to know that? Because there is a physical representation. When patients would be saying to you that they are feeling suffering, yes, there is a physical representation of this. And just saying to people that this doesn't exist, yes, I find that is not correct, because this physically exists. You are activating areas that are similar to when you are experienced. So more function MRI, so we know that nociception leads to pain. So of course, as much more activation of receptors, more areas you activate. Yes, more brain you are activating. So they put in just the intention, yes, the intensive of this stimulation. So as much as you put, more areas you are activating. But we also say that if you feel more pain, you activate more areas of your brain. So the intensity of the pain is being represented. So here if you look, low stimulation, high stimulation, so you have more areas, and then they subtract both of them to just highlight, yes, that there is a physical representation of, if I intensify more my nociception, of course I activate more. So we ask, yes, if these changes that happens in the brain, yes, if it's just now, we can say that is nature or nurture, is because now I'm changing more, that I'm causing more areas in my brain to be activated, or is the other way around, is because I activate more areas that I now feel more pain. Yes? So can you understand it? Is that because of the stimulus the outside makes my brain to stimulate more, or is because my brain stimulates more than her that I feel more pain than somebody else? Yes? So genetics is also involved in the experience of brain from, so varies the experience of brain. So what people more know is that the brain is not simply receiving, there is the descending modulation. So this slide is to start to present all this idea of this descending modulation. So that's the way that we see that is just cutting from the bottom, so horizontal, horizontal, all these horizontal sections like we saw in the practical in the first day, from the bottom to the top, yes? So from here to there, yes? So, and areas activated, but we know that there is a huge descending modulation employing endogenous opioid peptides. So it's mainly a lot of transmitters that you heard, but there is a lot of peptides involved on that. So what we see here is this modulation of pain. So we say that the modulation happens, descending modulation, but happens in many areas, in the spinal cord and also in the cortex coming down to the spinal cord. So we saw one example of happening just in the spinal cord. That was the gate theory. So the gate theory, we were just talking about how one fiber can win the other one, just there in the spinal cord. But we know that there are guys coming down as well. Coming down from where? So if we start by here, we know that information that comes to the spinal cord goes up, yes? And goes up and gives us, goes to the thalamus, yes? And then gives us the sensation here of pain. But from the cortex, we have influences in the PAG, periaqueductal gray, that goes to other places. This is raphe nucleus that is very important for attention in the brainstem, and then comes down to the spinal cord and is influencing all this information that's going up. Other areas important that we're saying here, reticular formation, lox ceruleus, that is very important also for attention, modulation of the cortex, raphe nucleus, this other area, nucleus reticularis. So all these guys are being pointed of modulating information down, but periaqueductal gray are on the top of them, and they are important. So there is a number of regions important in this modulation. But two very important ones that I would find that you need to know more is this one, the periaqueductal gray. So this is the brainstem, and then they cut here, yes, they show here these two areas, the periaqueductal gray and that area, rostroventromedial medulla. So these two areas are very important. All the descending modulation that you saw before in the previous slides are coming to these areas and then going down to the spinal cord. So that's what you're seeing here. So you have a number of areas, and they are coming down, yes, to this periaqueductal gray, and then goes to this other area that is a bit lower in the medulla, and then comes down to modulate the spinal cord, what is going up. So we say that in this rostroventromedial is the last one. Is the last one, because the periaquedutal gray is on the top and will now influence this last guy. So we say that in this area, the rostroventromedial medulla, we have off cells and on cells. So this is quite new, that they found out that there are cells. Why they classify? You guys are chatting too much. So they find that I want you in lecture, but I want you quiet. So people find that these two cells are different cells, and the reason that they are different cells is because they act in different receptors, and that is it can be seen. So which receptors you're seeing here? These receptors for what? 5-HT. What's that about? Which transmitter are we talking about? Serotonin. Yeah, alpha-2. Which transmitter are we talking about? Noradrenaline. Noradrenaline. Yes? So that is just some examples. And then Sarah is going to talk to you about what chemicals she's giving. Yeah, antidepressants, the acts there. Yes? So other ones that act there. I have been discussing that a lot of treatment involves GABA. That has not been put in so much here, but from what I could understand from Sarah, is just modulating calcium channels, and now calcium decreasing calcium, blocking calcium channels, you don't release so much transmitters. And it's also a way to block information processing. But so we know that these cells acting in the spinal cord in different receptors, and they found, so these guys here, 2 pictures of who? What you roughly recognize in these 2 pictures? Which part of my nervous system is that? Say? What is that? Is that my brain? Is that my insula? What is that? This is my spinal cord. This is my the dorsal horn of the spinal cord. Yes? So what is written here, encephalin, substance P. So substance P is taking the information of pain, is a transmitter that is very much found in nociceptors. And encephalins are modulating down. So in these neurons here, we have a lot of substance P, but they found receptors for encephalins on there as well. So what else more? So a lot of other receptors for opioids, cephalins, endorphins, dimorphins, yes? So there's a lot of receptors that are found in the spinal cord, yes? And that are agonists of these receptors. So that's what you give to activate modulation, yes? So a lot of drugs that are being acting in these receptors are modulating pain, okay? So then, towards now more to the end of what I had to say to you is just the introduction to the idea that you're not going to treat only chronic pain, but chronic pain is really the big business that happens that affects more people. And despite that people have a lot of causes that they don't know what causes chronic pain, mainly can be said to be subdivided in inflammation and neuropathy. So the way that is differentiated, so anything that is nociceptive comes from there, and anything that affects the nociceptive, yes, so inflammation would be affecting that bit here, the receptor, yes, and anything that would be affecting now the neuron, yes, the nervous system, would be neuropathic. So either the first neuron, the nerves that are in our body, yes, or the second neuron in the spinal cord, or the third neuron, so anything up to the cortex will be considered neuropathic, okay? But there is a lot of what people call idiopathic that they don't know. So neuropathic or nociceptive or inflammatory are the 2 main types of chronic pain, yes? And I put 2 slides about these 2 conditions here that cause a curiosity, because people are, especially the rheumatoid arthritis, that people have been finding that was purely the nociceptive, purely periphery, and they have now discovered that is not just that. So I come back. So if you follow here, this is the nociceptor, yeah, and that is the other types of fibers that are for touch, myelinated, have myelinated. So stimuli, any stimulus that provokes pain, firing action potentials there, and the person feeling pain. Yes? Now, if you fire, yes, if you present another stimulus that now is a tactile stimulus, you are going to activate the other type of fibers, yes, the other type of receptors, the A beta, and you're going to feel touch. That's what's normal. So people have found that in the case of the rheumatoid rheumatoid arthritis, what is happening in reality is that. So when now, yes, you are activating these fibers that were supposed to not cause any pain, they develop this branch here, and they activate now the fiber that was pain fiber. So this is happening in the spinal cord, because where these 2 guys comes together in the spinal cord. So these 2 fibers, either from the nociceptors or for tactile, meet together in the spinal cord, but they can activate each other because they converge in the same neuron. So they find that there is a modulation, a central sensitization that is now causing allodynia or hyperalgesia. So either pain when you're not stimulating pain receptors, yes, or now the explanation for hyperalgesia is that you are activating more that specifically neuron, more than normally. So this guy here, yes, is not so pink like that. So in hyperalgesia conditions that now you have an acceleration, exacerbation of your pain, in conditions like that, allodynia, that you have pain even when you do not have activation of the nociceptor, when you produce pain. And then you would imagine that the person is creating that pain, but there is a physical representation for that being happening in the spinal cord. Okay, by now the receptor for tactile activating the fibers for pain. So what did we miss here? So in the case now, so we had two types mainly of our chronic pain, the one caused by the tissue damage or the nerve damage. Yes, so they are periphery, yes, but they have now, they cause, yes, a central sensitization, and that's one example that we saw there, and can cause now hyperalgesia, allodynia, that is when we now activate, we feel pain without activation of pain. So all because of the central sensitization that can happen in the spinal cord or upper, yes, we can now decrease the threshold in the periphery. Yeah, so we can feel pain for nothing. Yeah, you can have an expansion of the receptive field in the periphery, so you feel more. Yes, increase the spontaneous activity. Yes, so you have this spontaneous pain by increasing spontaneous activity. So what is known is that pain is not just a product of this periphery, but we have these mechanisms happening in the central nervous system, spinal cord and superior, modulating this activity that is coming from the periphery. So that was the two conditions about the inflammatory that people have always thought that was just peripheral in the receptor, and now they find that suggests secondary plastic changes in the central nervous system, in the spinal cord. Yeah? So what happened in inflammation? So this is the idea that the receptors are being activated by chemicals released by tissue damage. So they can be activated not just by extremes of temperature, extremes of mechano activation, but also chemicals released by tissue damage. So tissue damage sensitizes, increases the production of pain by these guys that are products of the tissue damage activating more, sensitizing, making now more pain to be sensed. So if you have tissue damage, you are activating not just by mechanical activation, because you put damage mechanically the nociceptors, but you also have multiplication of that activation by these chemicals. And that is called, is the explanation for us to feel this idea of hyperalgesia. Allodynia would be without activating that receptor, and we still feel pain, and that is now explaining that can happen in the first neuron in the spinal cord. It has also possibilities that is being descending modulation. So neuropathic can happen anywhere in the peripheral nerve, in the central, in the nervous system, either in the nerve, peripheral level, spinal level, brainstem level, or anything to do with thalamus and cortex. Why? Because the pathway going that way. So anything that affects there, syringomelia is a type of neuropathic pain. Yes, anything that affects the pathway would be neuropathic pain. Another thing that you're going perhaps to read or to listen is about negative and positive symptoms. So negative symptoms is when you don't feel something. Yes, when you lose specifically, when you have a loss of a sensation. And positive, when you have a production. So allodynia would be a positive. So a secondary hypersensitive would be, sensitivity would be a positive symptoms. So neuropathic pain can cause both of them, can cause a loss of a sensation, but can cause production of that. So two cases now, allodynia, that's a positive. These two are positive symptoms. So two examples of positive symptoms of neuropathic pain, caused by neuropathic pain. But now you can also destroy by damage. You can destroy fibers and you can have negative symptoms as well. And to finish, I'm not going to spend too much time in relief because that's more what Sarah is going to talk to you. But the relief of pain is, of course, what everybody wants. But we say that it's not so simple. Yes, it's a multifactorial phenomenon that depends on the cognition, the mood, the personality, the context, and more. So I put this, depends on the chemical, yes, and that's pop is, yes, so opium. But it's not depending only about that. And more people are realizing that and making research on that. So pain can start here in the periphery, in the receptors. Local anesthetics will act there in the fibers, in the conduction of the fibers. So conduction can either here in the conduction, yeah, anywhere conduction of the impulse, yes, in here in the neurons, yes. Then opioids in the central nervous system, we start to have more the idea of opioids action. There are other technologies that procedures that is being done. So this idea of inserting electrodes. So what you see here would be the level of the ears. So stereotaxic is where now you have specifically measures. So you put the person hold the head in through bars here to measure exactly the reference. Where are you going? So when you do surgeries, so I have experience not in humans, but you have to know where you're going. So you use MRIs, previous MRIs, to see specifically reference inside your brain to say, okay, if I want to go to the insula, I need to go 3 centimeters from my front of my head. Yes, I have to go 4 millimeters in this way. So you have this stereotaxic reference. And people have been putting implants in the periaqueductal gray, thalamus, areas that are supposed, but periaqueductal gray, cingulate cortex. People are removing cingulotomies is removal of the cingulate cortex, some thalamic lesions, but this is very much, from what I understand, experimental done. Cordotomies, so surgeries, I put here a picture, that you can destroy because the anterolateral system is so lateral, you can just destroy or try to destroy that. So I think that Sarah can comment more about these implants, that stimulations in the spinal cord, stimulations in the nerve that is regularly being done, that she's going to address as well with you. People say that a lot of research has missed to do MRIs and function MRIs of the spinal cord. So that's something that usually when you read about function MRI, when you see pictures, is everything about the brain, but not the spinal cord. So they have looked now, function MRI of the spinal cord, yes, to see now that attention modulates the spinal cord response to pain. So this graph is just showing the parameter, the intensity of pain, yes, and just now, when the person is paying attention, not paying attention, yes, and how can modulate. So this is just an image of the spinal cord, yes, and they try to show this blob here is specifically how now looking at what the spinal cord. So you can look at the spinal cord and see function MRI and see how attention, for example, modulates at that level already. We were talking about placebo. So Suhai was trying to explain what is placebo. So placebo is an effect, yes, that people have to change your experience of that sensation, but that you believe that you are taking a specifically treatment when there is no chemical components there. But we know more and more, yes, that it can work, yes, because depending on that, the conditioning, the learning, the expectations, they modulate endogenous opioids. So people know placebo has an effect on these opioids. So this paper that I was talking as well, that's by Irene Tracy, that they give 3 conditions about the role, the potential, yes, the potency of this expectation in the therapeutic setting. So don't underestimate the patient-physician interaction. That's exactly how it's in the paper, yes. So, and they bring that to citations that Hippocrates will say, oh, make frequent visits and inquire everything. And the other one will say, he cures most successfully in people who has the most confidence. And that was said so many years behind. Yes, so that is just to show that it's not something new. Yes, that is something that is there in history, that people who believes that they are going to get better is really going, it works. So the three settings, A, B, C, so in this here, so expectance, yes,